Namaskar, Sat Sri Akal, good evening. A warm welcome to all our listeners today and a warm welcome to my chief guest today and Dr. Sunita Tandulwadkar, our Fogsi president. Today we are having 205th podcast of Gyan Pravah, that is flow of knowledge. This whole idea was of our Foxy president only, a very visionary idea where we bring all the guests from other specialities and maybe life coaches and maybe even actresses have also come and we politicians have also been there. So we try to interact and try to learn the other things also, like not only gynecology. So it's an absolute privilege to be interacting with two stalwarts of Indian medical field today, Dr. Sunita Tandulwadkar in reproductive medicine and Dr. Vijay Trehan in cardiology, each a pioneer in their own field and yet unified by their brilliance, vision, and legacy. So first I'll introduce Dr. Sunita in few words because she doesn't like to be introduced every time. But ma'am, the episode, the listeners may be different every time. So Dr. Sunita is an eminent leader in reproductive medicine, IVF and gynecological endoscopy with an illustrious career that has spanned over innovation, research, clinical excellence, and she currently serves as head of the OBG department at Ruby Hall, Pune, and also contributing as advisor and consultant to the IVF and endoscopy department at DY Patil Medical College also. She is a visionary entrepreneur and she is the founder and medical director of Solo Clinic, a center for excellence in infertility. And Dr. Vijay, I would like to tell you that she is the one who has done stem cells in a 45 years old lady, and then from self egg that lady could have a child. So we are that was really
Girish Hiremat must be knowing about all this.
Girish now doesn't practice so much.
Yeah.
Jagdish does the practice. But sir, stem cell, I am into autologous bone marrow derived stem cells and adipose tissue stem cell for last 10 years. Not as a gynecologist, I entered in. My mom was on a deathbed and she was not ready for a dialysis. Her kidneys were failed, and to regenerate her kidneys, I started my own stem cell because 10 years ago, no one was doing a stem cells for a renal pathology. And that time I realized the stem cells huge potential. In fact, Dr. Parvez Grant and everyone, Sunil Sathi and all, another day, last week, my aunt 75, we did an angioplasty. I did her stem cells, and through her right and left coronary, we injected her autologous bone marrow stem cell. They say, hey, always design a protocol for us also. I said, no, I'm not going to do that. If you are a cardiologist, want to do some history in the country and the world, you read about it. There are so many publications. In fact, 2022, Tirunelveli Group has written a beautiful review article on stem cells autologous in cardiac, and they have beautifully reviewed how it works. Many projects are there by across the globe. They compared all the projects. It's a beautiful, sir, 2022. You can read that. I will send it to Poonam and Poonam can share with you.
Actually, we are aware about stem cell for last almost 4 decades. About 3 decades ago, they have been used for cardiology. The only problem used to be that they have regenerated these cells, but the intercalated discs were not connecting with each other. So you have a lot of myocytes getting grown, but they are not really effective. And they used to be kind of causing intracellular electrical disarray, so they used to be rather responsible for tachyarrhythmias. So far, as far as the world form is concerned, I'm not aware whether they have made any tremendous leap and improvement in the cardiac functions, but it's a news to me that you injected both on right and left coronary artery and you got the excellent results.
You must be knowing Dr. Makhle and Dr. Grant and everyone. You can talk to Dr. Makhle. He only has put up. It was a complicated case in Nagpur, my aunt is, and she was advised bypass. So I said, bypass करने के पहले आप आओ मेरे पास रूबी हॉल में, and let me see by ballooning, by dilating, whether they can put in a stent for you. And if not, then the bypass, Dr. Ranjit Jagtap also is a very dear friend. We can always think about it. And we could do her stenting. And then 1 hour prior, I had removed autologous bone marrow and we did intracoronary injections to it.
That's right. Great
Dr.
news.
Sunil Sathe, you also must be knowing, he is also a great cardiologist. He has shown a tremendous passion, especially in cardiomyopathy patients who are probably too much on a waiting list and or cannot afford. Probably these are the candidate, but I can't work for them because I have my own enough workload.
Yeah, certainly. Some people have to come forward.
They have to design the protocol,
Right.
their inclusion, exclusion criterias. And probably, I think, sir, we will remember this beautiful evening a decade down when every cardiologist will be doing it. Now, many
Sure.
infertility specialists, my
Actually.
first baby I delivered in 2018. And in 7 years now, at least 30% of the infertility specialists are doing intra-ovarian or endometrial regeneration. We have
With
founded
stem
a
cells.
society also, and they are working because the government law is not allowing egg donation, surrogacy. Automatically, they have no choice, and everyone wants to work, and the things have happened. So probably a decade down, even cardiology it will be. I don't think decade, but in 4 to 5 years, many more people will be talking in your conferences. More people will get stimulated to do. Government laws will become little more flexible. Inclusion criteria will increase by the government. That is also another hurdle, which we are working with the health ministry at present.
So, in the words of our Prime Minister, Abada mein opportunities. So, if the government is not allowing something, so that gives an opportunity to go ahead.
I tell them, I was telling them the same, that आप बोलते हो make in India, but then US जब आपको green signal देगा तब आप follow करोगे. Let the colored skin do something before the white skin start doing it. It is important. And we could make a world record. I think it's very difficult to make a world record in our field because not necessarily we are not intelligent or creative, but we don't have a research orientation background with us, and government doesn't support researchers in private sector. That's why the things lag. In government hospital, they don't have a time for research. They are overloaded with the patient volume.
Overburdened there.
But anyway, today's podcast is about your.
So I have to introduce Dr. Vijay, ma'am.
Yes, and I'm here to hear you.
With over 35 years of excellence in cardiology, Dr. Vijay is a legendary figure in the field of cardiology, and he's a hardcore interventional cardiologist, formerly the director and professor and head of the cardiology at GB Pant Hospital for more than 30 years. And he has been mentored to and still mentoring more than 2,000 cardiologists all over the world, including India. And he is a distinguished academician and has served as examiner and faculty selector at institutions like AIMS, SGPGI, PGI Chandigarh, and many private institutes also. And he has also led the PhD program in interventional cardiology. And he is renowned for his clinical brilliance. And he did mitral valvotomy, balloon valvotomy, which they say, in 62 patients in a day and made the world record. And that was done in 2004, and 20 years down the line, nobody has matched him till now. So it's an absolute, pleasure to have him here with us today to discuss what clues we can have so that we can identify the assaults which is happening to our heart at the right time.
Thank you. Thank you.
So, sir, you are most welcome. And I was really enjoying the discussion between the two brilliant people. जिस stem cell का मुझे कुछ पता नहीं है.
This podcast is to give a platform to my chairpersons. There are 30 chairpersons, so everyone has been given one day in a month 12 months, 12 podcasts. They come out with the academic, non-academic, social, philosophical, political background. And believe me, more than my chairperson, I think I got evolved listening to many more global personalities and Indian personalities. Meeting them was an honor. I joined just 5 minutes to say welcome from the Fogsi side, to show our deep respect from Fogsi, sir. So thank you so much for taking out your valuable time, and I'm sure everyone will enjoy this dialogue. Poonam is known to make it more interactive, more with her smiling face. I want to know who has put up the stains in this lady.
Sir.
The same day, the look at the commitment.
Same day he made me sit. He said, podcast, कोई बात नहीं, 4 बजे रेडी हो जाएगी. 7 बजे तुम तो बोल रही हो, 4 बजे रेडी कर दूंगा.
Actually, when I heard Poonam has undergone angioplasty, I made another chairperson come back and probably might have to do on that day because we can't have a break. And 7 o'clock, this lady gives me a call. Dr. Trehan told me, if you can't take the podcast, then what's the use of me putting a stent? By putting a stent, I made your heart normal. I just love that. I love the confidence of a surgeon. Being a pioneer endoscopic surgeon of the country, I know how much surgeons should feel proud of their patient. And thank you, because of your stent, we could have Poonam's podcast on the same day. Her dedication is unparalleled. Thank you.
Thank you, ma'am. Thank you so much. Thank you.
Listen.
Thank you.
And it will be lovely to meet you sometime, sir. Thank you. Are you coming in Mahabaleshwar in mid-November? I think you have some cardiology conference.
Really. I'm out of India, November. And
because Sunil Sante was asking me, Sunita, why don't you give a talk in our cardiac conference with your stem cell? I said, same days I have my own conference in Pune, my presidential conference. But nevertheless, we'll definitely meet sometime, sir.
Catch you sometime. Yeah.
Thank you.
Bye-bye.
Thank you so much, ma'am. So, sir, let us go on to our conversation. So, first, tell me that why is cardiovascular disease often called a silent threat?
Silent threat? I said not only threat, it's a silent killer. Threat is something you just threatening. No, it is not a threat. It's a silent killer. In fact, if you look at the mortality statistics, I've not gone through the questionnaire and read, but what I can tell you is that general feeling is that the cardiac problems are male problems, men's problems. That's incorrect. Absolute myth. The fact is, females get affected, if not to the same extent as a male, they are also affected to a great extent. So much so that a lot of people are worried about ladies have ovaries, ladies have breasts, and ladies have uterus, and they have uterine cancers. If we put all the cancers on one side and we put the cardiovascular problems on the other side, cardiovascular problems, they account for nearly 8 to 10 times the mortality what you see with all the cancers taken together.
Okay.
So the toll by the cardiovascular problem is such a high, and the general impression is that it's a male's problem. So, and the other thing why we call it a silent is because 2/3 of the ladies who die because of heart attack, they do so without anything. Means they're kind of spot dead, or they get symptoms and they're suddenly dead. So 2/3 of the ladies who get heart attack is painless.
Acha. Oh.
Illness means swarg sidhar gaye and then nothing happened.
Fir pata chala.
And the second thing is, a large number of those who get some symptoms some of them might get classical symptoms, Bollywood style, severe pain, sweating,
severe pain.
But a large number of females, they don't have these symptoms. And if they don't have these symptoms, what happens? They have atypical symptoms. And in fact, if you ask me in my terms, I will say the typical presentation in a female is atypical.
Yes, that
So
is what you
atypical is
told
typical
me
for
when I
for
called you.
females. And what is that atypical is that now and then you keep listening to some news and sometimes some articles appearing in national dailies that there
Uh,
was an executive and she was like in mid 30s and she just had a little bit of dyspnea while taking stairs
uh,
and she thought she'll consult a doctor and then with that little bit of
Particular.
dyspnea she found to have a
Uh,
massive heart attack. So the symptoms in in females are more often either they are not there and
mm,
or lose their life, unknown, unseen, unsung, or if at all the symptoms are there, they are not so classical of heart attack, which some of the people who are like if you in the community, most of the people know that if you have a severe chest pain, sweating, gabrat, and so many things, then
तो आपको
possibly heart attack. But if what if somebody is having just lack of energy,
and just lack of energy, just jaw
just lack
pain.
of energy,
Mm,
and some of them might just have symptoms in the kind of epigastrium, some
mm,
nausea, sometimes
okay.
vomiting,
अच्छा nausea भी okay.
nausea, vomiting, sometimes just you're drained out,
अच्छा.
you have no energy, and you seek a medical consult, and an ECG done that tells you oh, you have something bad inside your heart. So
So
symptoms, then then a lot of them which we commonly see may
mm,
have nothing in the chest, absolutely nothing in the chest, may have
okay.
something in the throat, something in the jaw,
Jaw okay.
something in the tooth.
अच्छा.
Somebody having a problem in the tooth. Let's say you've had a
हाँ,
problem in the tooth, and you
हाँ,
you got some kind of a RCT or whatever done. Now 2, 3, 4 years down the line, you got a heart attack. That heart
mm,
attack pain doesn't come in the chest. It goes in the form that you have a worsening of tooth pain.
okay.
So these things are far more
So
common. Sometimes pain in the back. Some people will say, I
अच्छा.
have cervical for some time. Now the cervical is worse. So
हाँ,
if the symptoms of cervical were there and those symptoms are getting worse despite whatever you used to do something and they used to get better, they are not getting better. Similarly, sometimes
then we should consult.
just tiredness, just lack of
तो
energy,
ये this is a
sometimes
news
just
to
cold
me के
sweats.
this is a news to me कि if you are feeling fagged out or tired and we always used to consider कि ये कोई मतलब mental health issue ज्यादा है.
Actually,
Deficiencies आपने देख ली
biggest,
mental health issue ज्यादा है
the
but
biggest,
cardiac issue है ये नहीं कभी पता
the
था.
biggest problem with women is you tend to kind of overlook, neglect, and you just
हाँ,
see that she's kind of malingering, whereas
हाँ,
she's suffering. So often either they will not tell you, or they themselves are not able to interpret it well. But even if they tell it, leave aside telling it to your kind of family members. If you go to the hospitals, many a times a lady is come with nausea, with vomiting, with hiccup, with gabrat,
हाँ,
and you what you do is you just give them antacids.
हाँ.
So even after
Antacids
you
and
report to the medical
antidepressants.
personnel, even they are not
हम्म,
able to kind of.
हम्म.
So I'll
तो
say that
ये रेड फ्लैग्स हो गए ना हमारे सारे मतलब के अगर आप किसी नॉर्मल सिचुएशन मतलब कोई सिम्टम है वो आपके नॉर्मल ट्रीटमेंट से ठीक नहीं हो रहा तो उसको फौरन ध्यान देना है मतलब.
very important, very important. In
हम्म,
fact, in ladies, I have seen some patients just
हाँ,
presenting with cold sweats.
अच्छा. अच्छा
Nothing
कोल्ड
else.
स्वेट्स हम तो मेनोपॉज में ले लेंगे इफ शी इज
So
45 प्लस.
so if cold sweats are there,
हम्म,
what I mean is you just ask her, are they the same kind of cold sweats or they're different? Similarly,
अच्छा.
somebody is having belching, ask them, is there a kind of a belching which used to get relieved by simple antacids? They will tell you, no, belching is there, but it's not getting relieved.
हम्म,
Sometimes some numbness in the hand, numbness in the arm.
ओके.
Females very often they have symptoms which many times it is very very difficult for us to interpret. But I'll say that the difficulty in interpretation is only if you do not suspect. And
हम्म,
I think like you said, it's a silent and
हम्म.
threat. I said no, not silent threat. It's a silent killer.
साइलेंट किलर.
What I will say is that we should break the silence by
राइट राइट
meeting like
एब्सोल्युटली.
this. We should have some. I'll say that some noise should be there. That here is a problem which takes the life of majority of the women much more than the lives taken away by cancer of breast or cancer
Cancer.
of ovaries or cancer of uterus. And if you make a noise, then the silence is broken. And
Mm.
the moment you start making noise on different platforms, that means you're
Mm.
educating each other. If you're educating each other,
Each other, obviously, that
let
will.
me tell you, this large part of cardiac mortality is related to different etiologies is preventable in females. Large
Mm.
part is preventable. See, a lot of time we people say, oh, you have a genetic involvement, your father had it, your mother had it. So what can we do? We cannot do anything. What I commonly say is that your genotype, fine, you cannot change. You can't change your paternity.
We cannot change.
You can't change your paternity. Also, you can't change the advancing age. But
Mm.
genotype is almost like a gun which is loaded.
Mm.
So let's say you have a genotype, it's like a gun which is loaded, but the gun has to fire now. The gun fires because of precipitation. And the
Okay.
precipitating factors are other risk factors. And if we
Ah.
know that these are risk factors can be modified, then a lot of people have a loaded gun but which doesn't fire. So you had a family history, but you never got a heart attack.
Yeah.
And
Got it.
if you are aware that you can get a heart attack, if you are
Acha,
aware that
acha, why now the young people are having heart attack? पहले तो नहीं सुनते थे हम इतना
Abhi,
कि young people
no,
are
I quite
involved.
agree.
Now young
See,
people अभी आप ये सुनते हो कितना young लोगों में हो रहा है? Why?
not that it was never heard. I remember some 30 years ago having done an angioplasty on a 17 years old boy.
17 years old. But we
Yeah.
never heard
After
things
that,
like that. Okay.
after that he got married. He's fathered many kids now, so he's living fine. He came to me
अच्छा.
from birth. So, but those used to be very very rare events.
Hmm.
Nowadays, I will say they are not that
Very
rare.
common.
No,
Not that rare.
they are not
Okay.
common. No, let me.
Not common.
They are
Okay.
not common. Even
वो
even
क्योंकि
today they are
ऐसा
not
कुछ
common.
होता है, it comes in news and we hear
Yes,
it very
yes,
often,
yes,
तो
yes.
आपको लगता है कि इतना हो रहा
Because
है, इतना हो रहा है.
if I look
Maybe.
at my
Okay.
practice the last 3 to 4 decades, I will say that probably their number is kind of increasing a little bit,
Hmm.
but not as much as you have a news item which is kind of goes into loop and then 10 different channels.
So why it is
But
increasing?
whoever is
Maybe
getting it,
because of our lifestyle.
yeah, certainly because of lifestyle.
Okay.
Whoever is getting it, see, a couple of years ago there was a lot of blame given to COVID and or COVID vaccine. But I,
हाँ, अभी भी है. It's there right now also.
but
People say कि मेरे COVID
there's a
vaccine
big
की.
study which has come from Mumbai that was, I think,
हाँ.
3 or 4 days ago, and they
Hmm.
have kind of negated this theory that either COVID or COVID vaccine has something to do with it. But I'll say that if you look at our lifestyle,
Hmm.
I'll say that the gun is loaded, but our lifestyle are the frustrating factors. In the lifestyle, see, there used to be a time when people used to work very hard,
Hmm.
and like in the field, if you have a if you have a like if you have a animal or you have a bull with you
Yeah.
which is supposed to
Hmm.
do the task and the bull has gone sick, so you used to take that thing or
Hmm.
do it. So you used to work
Hmm.
very hard, take a lot of ghee that used to be digested. Nowadays
Hmm.
we don't want to do anything. We are standing in front of the elevator or lift, we are waiting for taking the first floor.
Yes,
in
absolutely.
in a winter season, if you are in a quilt, there is a
Hmm.
remote of the television, and if you
Hmm.
find that remote of the television is gone somewhere lost in your quilt, then your wish and desire is that there should be some remote in my hand somewhere which can find out this remote. So
Okay.
our
हाँ,
activity
है
level,
तो ऐसा ही. Hmm.
see, activity level has gone down, and
हाँ.
the mental activity starts early in the morning. You start thinking big things.
Hmm.
Everybody is now aspiring big things because media exposes to you so many things. So
Hmm.
what I'll say that your activity level has gone down tremendously, your mental activity has gone down or it has gone up tremendously, and your lifestyle. See, previously people used to eat and work. Nowadays, if you look at it, dairy products. Now dairy
Hmm.
products are relatively freely available to most of us.
Hmm.
And there is a lot of adulteration in them.
Lot of adulteration, right? Hmm.
That food cannot be of having the same value. Similarly, we tend to use a lot of rancid as well as the trans fats.
Mm.
Like if you're taking samosa, you're taking bread pakoras, so they go through the same oil many times.
Many
This same
times in the same oil.
time,
Huh.
if it is burnt many times, it is very, very injurious to your body. So
Mm.
I'll say that this is one. Then a lot of people, especially youngsters, are going to gym. They are taking a lot of supplements,
Mm.
protein supplements. So many of them are not very well tested. And then talk about smoking, talk about
Acha,
cocaine.
that is the reason these few actors
Yeah,
which got heart attack.
yeah. See,
Those are the people who will, they will have a weight of 100 kgs, and then they will have a weight of 50 kg, फिर 100 kg, फिर 50
these
kg. That is how they
sudden
do because of their
sudden
role.
increase and decrease in the weight is one of very
Huh.
important risk which puts a stress on your cardiovascular system.
Sure.
A person who's obese, stays obese, has a less chance to meet with a problem in your cardiovascular system than a person who's
Okay.
not a 50 kg now becomes 100 kg and then comes back to 60
Then
kg
comes
again.
50 kg. Oh,
Treat it like this. So that
so
itself is a risk factor
that could be the
because
risk factor. Hmm.
that is one of the risk factors. And then
Hmm.
smoking,
Ah, smoking. Yes, yes, yes.
see,
Passive
smoking is one of
smoking,
very
active
important risk factors
smoking.
which the
Hmm.
Western world is leaving. Western world is
Hmm.
leaving. But this part of the world, I think this incidence of smoking is kind of going down, but still, I think this part of the
As an
world still smoking is
obstetrician,
quite rampant. If you go to
हाँ,
universities area,
as, हाँ, नहीं स्मोकिंग पेशेंट्स तो बहुत हैं
sorry,
नाउ देर आर यंग गर्ल्स दे आर आल्सो स्मोकिंग इनफर्टिलिटी के पेशेंट्स आते हैं दे आर आल्सो स्मोकिंग एंड
you go to
अल्कोहल
university,
टेकिंग
you will find them just
फ्रीक्वेंट हो गया काफी फ्रीक्वेंट हो गया
and
so now as an
and
obstetrician I
smoking
want
even
to
in
know
villages.
As an obstetrician, I want to know what is the red flag sign for me कि मेरे पेशेंट को कोई प्रॉब्लम इस पर्टिकुलर पेशेंट को जो ऑलरेडी बिल्कुल एब्सोल्युटली ओके चल रहा था इन एंटीनेटल चेकअप्स एंड दिस पेशेंट मे हैव सम कार्डियोमायोपैथी और सम अदर थिंग
Actually,
related to
see,
heart.
as far as cardiomyopathy is concerned, we're generally talking about a peripartum cardiomyopathy, which
हाँ
generally
पेरिपाटा
near almost is near term. See, it's a
हम्म
problem in the third trimester, and even in the third trimester, if you look at it, last month is the time when you
okay
start getting the problem, and most of the people who are diagnosed, they usually diagnosed. It's more of a postpartum cardiomyopathy rather than a peripartum cardiomyopathy because a large number of people they are diagnosed after they are delivered.
okay
So if you look at majority of the diagnosis is after the delivery. Of course, the problem starts during
हम्म
the time when the baby is in the womb, but majority of
हम्म
the people are diagnosed after that. But while the baby is in the womb, then what are the red flags? See,
हम्म
if I look at my practice in the last 4 decades, the our overlap with the obstetrician used to be primarily with hypertension, whether whether
okay
it is a simple hypertension or a preeclampsia or
हम्म
eclampsia. And
हम्म
for me, the red flag used to be the same. I think which is for an obstetrician. The one used to be that you keep a very close watch on your blood pressure and the blood pressure reading which are generally acceptable to non-pregnant ladies. Like it is 150, 100, so koi baat nahi, so we can give some drugs. So those kind of BP readings are absolutely unacceptable
absolutely unacceptable
because
yes in
the
pregnancy
blood-brain barrier is not all that good in those individuals, and they tend to present with catastrophic events with high blood pressures, and very often, much before a catastrophe takes place, I think they have visual disturbances. In the visual
Mm.
disturbances, either a diminished vision or sometimes
Okay.
diopters in the form of multiple lights being there,
Okay.
sometimes a double vision. So that I
Mm.
think vision is one part. If with vision, if you have some nausea and vomiting, and if somebody is also having headache, frequent
Mm.
headache which is not responding to usual medication, like most of the people
Mm.
get common headache. If there is a pregnant lady who comes and tells you that I've been getting frequent headaches and I used to respond to kind of dolo or whatever, and now this is not responding, I think for
Mm.
me this will be a red flag. And
Mm.
then change in the weight, change in the weight
Acha.
which
Okay.
we tell to most of our patients heart failure. If there is a
Mm.
significant change in the weight, which is generally is because of water accumulation, and you can see it on face, you can see it on tummy, you can see it on the legs. So if you have a significant change in the weight, then it should be. The other red flag for me is a lot of ladies who are pregnant, especially if they're twins, a lot of fluid in the
Mm.
tummy, then they tend
Yeah.
to hop and buff. If you ask, look at them, they are walking and they will say, "Oh, saans phul raha hai." But
Mm.
they are kind of habitual with this, because this, if they're a twin or there is a lot of fluid, this doesn't come suddenly. It is slowly accumulating. So get
Slowly,
tuned to
but
it. But if a pregnant lady tells you that she is short of breath, which is not the kind which it was there yesterday,
uh,
then
then it should be a red flag.
then I'll say that nowadays everybody at home has that pulse ox. Put that pulse ox on the finger and see. If you find that she's kind of inordinately short of breath, she's tachypnic, and her saturation has gone down, I think this is a big red flag, and this is what which sometimes we tend to miss. Even a patient misses it, and by the time you reach the hospital, you might have already have a progressed problem. Either it's in the form of failure or sometimes pulmonary embolism. I think these are two important issues which are because of cardiovascular issues which produce shortness of breath, which is out of proportion to the real shortness of breath.
So, as you
If
say
somebody
that,
has chest pain, if you're pregnant, if you have chest pain, then then I think everybody understands it's a red flag.
chest pain to chalo. Yes.
No, if it is a retrosternal chest pain.
In our patients also who are having, this recurrent pregnancy loss patients and the patients with bad obstetrics history, they all of them, I would say most of them will have high homocysteine levels. So I think that also makes difference in your field also.
Homocysteine is for us is a big culprit, especially in younger population, because it has a tendency to produce a prothrombotic state. So
Okay.
anytime I get a young male or female who has an heart attack, then the patient doesn't leave the hospital unless we get a full screen done for the coagulation factor, protein C, protein S, APLA,
Okay.
and thrombin 3 deficiency protein. And then we also look for cardiolipin and this homocysteine. And I will
These
not
are
say
the
that
same.
I will not say that they are seen in most, but you keep getting cases where you have at least one factor in the form of homocysteine, which is very, very easy to treat. I mean, it's just all what you have to do, just give folic acid to these patients. And
The active folic acid is to be given. Yes, B12, B6, right. So in these PCOS patients who are having then obese patients, then the patients who are having gestational diabetes. So in those patients also the heart problems are more.
actually, there are a couple of problems which come in pregnancy. One is a diabetes. Second is hypertension. So you have a gestational diabetes, and you get pregnancy-induced hypertension. I always say that. I always say that this lady has announced. She has told you that this is my future. In fact, a lot of people believe that this was in pregnancy, and now the pregnancy is over and the thing is over.
हम ठीक हो गए हाँ.
Look at the world literature. Those ladies whose blood sugar and blood pressures don't do well in pregnancies, they don't do well in the later life.
Okay.
In fact, if you look at anything which is away from normal, if your menarche is early, if your menopause is early, or it is delayed, or it is prolonged, anything. So those people, they don't do very well. So I'll say that if your blood sugars are not all that good, even if those things they get better after pregnancy, you should watch out for you in future getting diabetes. Same is true with your pregnancy and your hypertension. Some other people, of course, will continue to have hypertension, but many of them, in fact, large number of them will have their BP ratings turn to normal only for some time, and subsequently these are the people who develop hypertension again. So if a pregnancy has announced that you are going to have big risk factors in the form of sugar and blood pressure, I think it's a responsibility of the clinician, the obstetrician, as well as the physician and cardiologist, that we should tell it to the patient, educate them, and keep them under some surveillance, and keep them under such a control so that those things can be kept below the.
Yes.
And if let's say somebody has had a gestational diabetes and PIH, Now for this person, the cholesterol should be very nicely controlled. This person
Okay.
should control the weight. This person should always be no smoking and alcohol. So
Mhm.
all those things which are otherwise supposed, sometimes we can say it's okay, but I think having tasted diabetes and tasted hypertension during pregnancy, it's very important that सतर्क हो जाएं. We should be careful in the coming time.
अच्छा, sometimes I really wonder, जैसे in countries like US and these European countries, those people, they eat salad only. They don't eat so much of fat the way we eat so much of fat. But lifestyle is sedentary, theirs also and ours also. So why do they have so much of heart attack, maybe more than us?
No. If your
We are
life,
having more.
let me tell you, in the heart attack is
Mm.
like an accident. And if somebody asks you, Dr. Poonam, why do accidents take place? So what will you
Mm.
say? You'll say either vehicle was not good, or the driver was not good, or the traffic was not good. And then you have
Mm.
10 factors related to vehicle, 10 factors related to that driver. He was not slept, he was taking alcohol, blah, blah, blah. So similarly, heart attack also has different risk factors. What you can do is you can only control the risk factors. If you are, like if you're looking at the Western people, if you look at the Mediterranean people, their diet, which is Mediterranean diet, in which they take lot of salad, lot of fruits, and they lot of take legumes, and then
Ah.
they don't take an unprocessed kind of anaj. So these people, there the chances of getting heart attack are very less. On the contrary, if you're talking about, let's say, US people, so US people, sometimes you are able to see that they are taking a lot of salad, but you are not looking at the rest of the food which they are taking. They are taking already very with that the dairy products which they take. I think
Dairy products are too much.
if you look at them, then I think the one serving will be like okay for us for a week. They take too much. So
So,
I'll say
what is
that
the role of stress and our mental health in this? Is there any role? कि सब वो जैसे पुराने जमाने में होता था कि ये बात सुन ली और उनको अटैक आ गया. सो
no
वो
no
क्या है?
no this is absolutely correct. In fact,
अच्छा.
absolutely correct. I'll give you an example. India-Pakistan का match. India-Pakistan had
हाँ.
a, and you find 10 heart attacks reported next day in a newspaper.
Oh.
And India lost. So that acute stress, see what it does, that triggers. You already had atherosclerosis. You had atherosclerosis at the time when there was a stress, and that stress was usually in the form that your blood pressure shot up, your
Okay.
heart rate went up.
हाँ.
This high blood pressure produced a lot of stress on the branch point of the arteries, and if there was a plaque at the branch point of an artery, this plaque, because of bombardment of high pressure, this plaque will break. If the plaque breaks there or ruptures there, then we have a thrombus formation. If the thrombus completely occludes the artery, this is a heart attack. So stress has a great role in acute events,
Sure.
but also has a great role in, see, most of the people who are stressed, they will have anything in common. I'll give an example. You say that he is a smoker. He takes a lot of alcohol, so he'll be gambling also.
हाँ, हो सकता
Isn't
है.
it? Same thing. If you have a person who's under stress, then those people who are under the stress, they tend to have their different eating habits. Either they will not eat, like anorexia nervosa is also a stress-induced problem, or a lot of people will tend to overeat. A lot of
Overeat. हाँ.
people during stress will tend to take alcohol. They will tend to do a lot of smoking, and sometimes they will also take cocaine and other things. So I think they are kind of interlinked things, and stress is a very important factor in causing heart disease and also triggering the guns so that a plaque ruptures and produces a heart attack.
So, 3 practical tips for every obstetrician to protect women's heart during pregnancy. क्या हो सकते हैं?
So I'll say that
Anemia.
if you're talking about pregnancy per se, then I'll say that
Pregnancy.
see, there are a few things which we didn't discuss. One is a heart syndrome, which we commonly see in females. That's that because of acute stress, the heart, some part of the heart stops working. Generally, it is the apex of the heart which is not working, and the picture in the ECG, in the left ventricle angiography, in the echocardiography, they're all exactly the same as in a heart attack. And this is only just because of stress. And as the stress passes, then majority of the cases, the same function comes back. If you examine their arteries, the arteries are normal. So this kind of a disease, that's broken heart disease, it is seen only and only in the females. Very rare to see them in males. The other specific problem which you see in females during pregnancy is the coronary arteries will get dissected spontaneously.
Dissected means?
By dissection, what I mean is each artery has multiple layers. So between the two layers, bleeding occurs, and the bleeding occurs between the two layers will split, and then one layer will tear. So a layer which splits will go down into the lumen. If it tears, it will go down to the lumen, so it can block the lumen of the artery. So some of the young females, especially during pregnancy, they get a heart attack. Then one of the commonest reasons for them is not atherosclerosis. It is the bleeding into, and this bleeding is related to estrogens, and also related.
But estrogen levels are not that high during pregnancy. Progesterone to hota hai.
No, it is related to estrogen, but then in estrogens, later part of the pregnancy, you have progesterone. Initially, you have estrogen.
Later part, initially.
So then what is said is that both estrogen as well as progesterone, generally they have opposite action, but generally the hypothesis given is that since it is specific only to pregnancy and it is seen both in the first trimester as well as in the second trimester, it could have something to do with the hormones. What they do is between the two layers they are bleeding, and that bleeding kind of splits the two layers. This is nowadays known as SCAD, CAD, that is spontaneous coronary artery dissection, and it is now considered one of very important causes of heart attack during pregnancy. It can occur otherwise also, but in pregnancy, like if you have a Marfan syndrome, you have aorta. Aorta can also have dissection during pregnancy. There is a medial weakness in pregnancy. The so-called supportive tissue, they become lax, and if they are lax, then the vasa vasorum have a tendency to bleed there. So I'll say that other thing is coronary vasospasm. So these are specific problems in pregnancy which can mimic a cardiac condition, because generally if you are like in your childbearing age group, you are in 20s or 30s, then estrogens kind of protect you from the onslaught of LDL.
That is what we hear all the time.
Generally, we say that it goes for a decade after you stop kind of ovulating. So even 10 years after menopause, you have some kind of protection going on, that umbrella protection of estrogen going on. But even when you have good umbrella protection, even during that time, you can have coronary vasospasm, you can have spontaneous coronary dissections, and you can have stress cardiomyopathies, which are not uncommon. And as we talked about this peripartum cardiomyopathy, that in fact we see it less often here, but if you go to African countries, and especially if you see in the African countries, there the incidence is very high. If you go to Nigeria, the incidence is almost 1%.
Achha?
Yeah, 1%. One lady out of 100 gets this peripartum cardiomyopathy. Here it's about, I think it's about 0.1%. 1 out of 1,000 or maybe 1,500.
0.6% कहते हैं, but I am also not very sure.
15 करके बोल सकते हैं,
but less than 1%.
And if you go to Hispanic people, go to Spain, you don't really see it. It's not seen there. So there is I'll say there is a difference in their presentation according to ethnicity, but this is a specific problem which I'll say that most of the gynecologists should know. And how do we diagnose these patients? At least the cases which I have seen, how they were diagnosed, according to me, they were diagnosed just because some of the obstetricians who had attended some lectures and knew about this problem, so they tried to and kind of analyze the symptoms. And what are the symptoms? Symptoms are usually the same as the patient getting heart failure. People will have cough, will have shortness of breath on exertion, and as the disease progresses, they will have orthopnea. Then at night they'll have kind of PND. But sometimes some people have only a cough which you cannot explain, and some palpitation. So the obstetrician suspected that there may not be a cardiomyopathy because she's delivered kind of hundreds and thousands of patients, but this lady is coughing inordinately even after she is delivered. This lady is not keeping her breath the way I used to see. So she thought, get an echo done, and the echo shows that the left ventricle is dilated, the ejection fraction is less, and all those features which are there. So I'll say that it is very, very important to suspect, and because diagnosis is very simple. Just get an echo done and the diagnosis is there in front of you.
Diagnosis.
Not only this, the other thing is that if you diagnose them early, then the prognosis is far, far better. Then if you diagnose them, if they are admitted as an emergency with shortness of breath in the form of left ventricular failure. So if you have a high index of suspicion, if the incidence is like 1 in 1,000, so I'll say that almost every obstetrician after practicing does thousands of deliveries. So
absolutely.
it's like this, then I think just have an eye that if you find a person who's coughing inordinately, has some shortness of breath inordinately, or has palpitation which are not explainable, I think it is sensible to just order for an echo, which is a very simple test. But I'll say that if you give me an obstetrician for 10 minutes, I will teach that obstetrician in 10 minutes how to make a diagnosis of dilated cardiomyopathy. It is so easy. So
what you have told us are the whispers of cardiac disease, which we need to listen. So, okay, that's now we are coming to end almost. So I'll have one rapid fire with you. Okay, jaldi, fatafat, one-liners. So, one cardiac symptom which you think is most often ignored in females. Most often we ignore that symptom.
Shortness of breath.
Okay. And one myth about women's heart disease which you want to bust. One myth ke ye nahi hai.
Sorry, I didn't listen to this.
One myth about women's heart disease you want to bust.
That I told you in the beginning. Don't believe it's a men's problem. You are kind of equally vulnerable. Also, get under the impression that you have 2 ovaries and 2 breasts and a uterus, and you can get a cancer there. Forget about that. You have 10 times higher chance to die of a cardiovascular problem than because of malignancy. Malignancy, you will be able to diagnose very, very late. Cardiovascular problem, you are able to diagnose much early. Malignancy, you are not able to prevent so well. You can do some kind of vaccination for nowadays you have vaccines which can prevent CSRH, but then cardiovascular can be easily prevented by just changing your lifestyle.
So what's the most underestimated risk factor for women's heart? Underestimated risk factor, जिसको हम बिल्कुल underestimate करती हैं gynecologists or obstetricians. वही same shortness of breath.
No, that is a symptom. But you are asking what a risk. I will say out of the risk factors, the most important risk factor for a heart disease is high or worsened lipids. And most of the gynecologists, they don't know about lipids.
Yes, most of the times we don't know, and in pregnancy we don't get it done because as such the lipids increase in pregnancy. That is why.
No, lipids
so we usually don't get it done in pregnancy, you know.
No, but I'm not talking. What I'm saying is that most of the time we are totally unaware that lipids is something also which can be done. If somebody has a familial hyperlipidemia, pregnancy is not going to correct it. You'll still pick them up. And treating these patients, at least making them aware that you have hyperlipidemia before getting pregnant, have your cholesterol down. During pregnancy, take care of your cholesterol intake. At least those things can be prevented.
We are trying that we are doing this preconception care. This is a very big project now of Fogsi. Dr. Sunita is taking care of that. And we are kind of making people literate about their health parameters. Lipid profile is one of them. So we are trying, but the goal is, very far away. Anyways, okay. One single lifestyle change that protects the heart best. What is the best single lifestyle?
There are 2 things. One is diet, second is feeding habit. So I'll say much more. Sorry, one is the diet, second is the activity, physical activity.
Okay,
So
physical
I'll say
activity.
two. If you just control your diet, is a much better
Okay,
way of protecting your heart than your physical activity.
okay. So yoga or walking, which is better for our heart?
Actually, most of the people who are doing yoga, they are doing just physical exercise without knowing. Yoga is not physical activity. Yoga is
Uh,
control of your autonomic system, which most of the
uh,
yoga teachers don't teach you because most of them they don't know. If you are a yoga expert, then you can stop your heart on your own. You can stop your breath for 3 minutes or 4 minutes. But most of the time, these yoga teachers only tell you that you do this flexion exercise.
uh,
Okay, that exercise helps you. But if you are able to do yoga exercise, that is far superior to than your simple physical activity
okay.
because
Okay, then
you
what?
are able to control your autonomy system.
Hmm. So, which is worse for the heart? Stress is worse or sugars are worst?
See, sugar is worse over a period of time. Stress
Oh,
is worse for the
acute.
jerk, for the jerk. So if there is a stress, you can have atherosclerosis, but sugar will have a higher chance to develop atherosclerosis, and stress will have a higher chance to burst the plaque and produce heart attack.
Okay. So, do you think the heart disease is overdiagnosed in women or it is underdiagnosed? I think what I could gather was that it is underdiagnosed in women.
Underdiagnosed. The underdiagnosis is at all levels. Patient doesn't believe that patient can get a heart attack. The doctor
हाँ,
doesn't believe that the lady can.
डॉक्टर को भी समझ नहीं आता. Okay,
Doctor
okay.
doesn't believe that the lady can get a heart attack. So
Hmm.
things are bad at both ends. In fact, we keep getting many cases where a heart attack took place and the patient did not die, but the heart got worsened. Large part of the heart is dead, and then the patient is brought to us 3 days, 4 days later, because then fourth day somebody suspected did the ECG, and then he said, "Oh, you had a heart attack 3 days ago." And what was the symptom of a heart attack? She said, "I just felt cold sweats." Second
Hmm.
person says that I had some shortness of breath. I had a loss of energy. And so those kind of symptoms are there, and so they're not diagnosed. Whereas if these symptoms are there in men beyond 60, then our index of suspicion is higher. We tend to
हाँ
diagnose
यार,
them.
हाँ, yes, you are very right. Everyone in the home will say कि heart attack हो सकता है. Yes, you are very right. Hmm. So, what you do to keep your heart healthy?
No, I'll say the standard principles. See,
Uh,
who I cannot change my paternity. I cannot
yes.
change my gender, which has a higher chance to get disease. I cannot stop the arms of a clock. So, three चीजें are non-modifiable, which are very important. The
हाँ.
genetics, advancing age, and male gender. But then you have to
Hmm.
do many things with you. You know what is your blood sugar, and you know how to control it. Simple thing is just don't try to pump in an unnecessary a kind of a refined sugar. Even if you have to take it from the natural sources. Then
Hmm.
try and have your lipids under control. Again, let me tell you, most of the time you don't need drugs. All what you need is just be aware as to what is your dietary pattern, which is going to make your lipid profile worse. So control your sugar, control your lipids, control your blood pressure. See, blood pressure to some extent can be controlled by just trying to take care of your body weight and trying to be into relaxation exercises. But some of us have a familial tendency to get a blood pressure. So if you have a blood pressure which is familial, then try to control it with the help of drugs. Whichever kind of drugs you use, finally the blood pressure has to be controlled. And then don't indulge into things like smoking and even a chronic alcoholism
Alcohol.
also to produce high blood pressure. So just try to take these things under your control. Eat healthy diet and learn to stay happy. Make others happy. More important to
Yes. Make
yeah,
others
make
happy.
others happy. The day
That's
you start
most
making others
important.
happy, you start feeling happy from inside. And I'll say that these are important things. You still will have many of the people with who will be kind of performing all these activities might still get a heart attack. Probably I'll say that that's beyond your control. But some of the
Mm.
simple numbers you can control. Control your blood sugar, control your blood pressure, control your body weight, and relieve the stress. Have your lipids well. Have your good diet, and don't get into smoking and alcohol. And I think majority of the people who stick to these things, they are able to avoid some of the cardiovascular problems. not all of them.
So, any experience with any of your patients जिसको सुन के you felt the God is great?
Many times I have had the opportunity to handle many patients who are kind of brought dead to you. They are kind of
Oh.
declared dead to you. And
They
I
could be
remember
saved.
one patient some
हाँ
25 years ago in GB Pant, when the
जी
patient was brought on a trolley, and it was brought like a dead body, and I was already busy in the cath lab and I was just going to come out, and they were supposed to take it into the ICU or into the emergency, and the attendant did not realize that the emergency on the right side, the lift se nikalte हुए, they came straight to the cath lab. And when I looked at the
okay
patient, tried to talk to him and looked at it and found that there is no breath sound and there is no heart sound, so he's nothing. So the first response whenever we see somebody who's not breathing or doesn't have a pulse is to start
हाँ
giving basic life support. So we
हाँ
started basic life support on the trolley itself. Then we are talking to the attendants. अरे भाई कब से हुआ क्या हुआ? He says कि नीचे तो बात कर रहा था जी. In the lift he was
अच्छा
talking. So in the lift he was talking. That means some 3, 4, 5 minutes. जितना ही time लगा होगा lift got go ahead. So we started to do massage on him, and massage didn't work. But we were in the cath lab, so we took the patient from the trolley onto the cath table. And in the cath table, because there was no pulse was coming, so I groin puncture karke we inserted a lead into the heart. So as I was trying to find a vein, rather than getting a vein, the artery, because there was no arterial pulse, so the needle punctured the femoral artery rather than the femoral vein. So I said, okay, fine, artery I is in it, put a sheath into it. So put a sheath into artery, also a sheath into the vein. From the vein we
okay
went into the heart, started pacing the heart. Heart is not working. Then we said, okay, arteries, the puncture ho gayi, let's take the catheter and see what is in the coronary arteries. We had not seen anything, no record, no admission, nothing.
अच्छा
I went to the angiogram. His right coronary artery was occluded from the beginning, and left की दो major branches होती हैं, उनमें से एक LED was also occluded right at the ostium. एक छोटी सी branch was, only small branch was running. So I don't know what happened. I thought this LED is occluded old, RCS के fresh हुई है. That time these new devices are not available. I took the guide catheter suction into the right coronary artery, started sucking out, and I must have injected some 200 ampules of epinephrine into his right coronary artery. And after about half an hour, his heart starts to work. His blood pressure came around 50, 60, and then slowly improved. And then we gave him blood thinners because a lot of clot in the right coronary artery. Then he kind of had some rhythm, had some BP of 70, 80. He was on ventilator. We shifted him into the ICU. Because of that blood thinner, because we found a lot of clot, he started to have bleed from the GI tract as well as from the. We gave him 25 units of blood.
okay
Finally, this patient walked out of the hospital 5 days down the line.
क्या
And,
बात
and
okay
while we were working, his brother came out with papers कि सर आपके अस्पताल में दिखा रहे थे इसकी इंजेक्शन फ्रैक्शन 15% थी, इसको सबने बोला था तेरी एंजियो नहीं हो सकती. So he had a 15% EF when his one artery was blocked, the other was working. अब तो 15 भी नहीं थी उसकी. But as luck would have it, we took him. If let us say this kind of a patient comes to me in the OPD even today, so I'll think 10 times should I take him to cath lab or not, because he has a very high chance of dying in the cath lab. But that day we didn't have any information, so we took him and God saved him. And then this fellow lived with that 15% ejection fraction for about at least 10 years. He was a peon.
Okay.
He was a peon in UPSC. He used to come to me and he used to always tell me, sir, just write me that I cannot do severe exertion because मेरा ठेकेदार मुझे बोलता है कि सीमेंट का तसला लेके 6 मंजिल ऊपर जाओ. मैं चला तो जाता हूँ, ये तसला लेके नहीं जा सकता. So that I just cannot forget that kind of a survival. After that, we've had many survivals like this where somebody was kind of either declared dead or fully dead, just about to be declared dead, and he worked hard and he blessed us and we made it.
absolutely
I always say childbirth and heart attack, they are miracles.
absolutely absolutely जो old people used to say कि बच्चा पैदा होता है तो ये दूसरा जन्म होता है ना.
बिल्कुल बिल्कुल. एंड हार्ट अटैक में जब कार्डियक अरेस्ट के बाद पेशेंट बाहर आता है, बिल्कुल ऐसे होता है. And this is not one case. We have seen now we have treated hundreds of such cases where everything had stopped, and then you're working and working and working, and then 2-3 घंटे massage करते रहते हैं, and then finally the patient makes. So
miracles do happen.
Yeah, and they tell you that you keep working hard.
Yes, absolutely. So it was so wonderful to talk to you, Dr. Vijay. I'm so enlightened, and I think our audience will also be enlightened. And I will get back to you again if I have this opportunity once more next year, maybe, or any other time. It was so nice to have you
Sure.
on our platform of Fox.
Delightful to interact with you.
Thank you, sir. Thank you
Okay.
so much, sir. Thank you.
Bye.
Thank you. Thank you, Ji. Thank you.